Welcome to Civic Buzz, a program of the League of Women Voters Minneapolis. I'm Ellen Van Iwarden, Program Director for the League, and I'll be moderating our presentation tonight. The League is a nonpartisan political organization that encourages informed and active participation in all levels of government, works to increase understanding of major policy issues, and influences public policy through education and advocacy. I'm thrilled to be helping the League with this work, and I encourage you, if you're not already a member, to join us. You can find out more at lwvmpls.org. Tonight, I'm honored to present Dr. Rebecca Thoman, who will speak to us about the Minnesota End-of-Life Option Act and the League's work to get it passed. We're in a Zoom meeting tonight, so you will be able to ask your questions directly to Rebecca when she's concluded her remarks. Thank you, and we look forward to your questions. Dr. Thoman leads the Doctors for Dignity Initiative for Compassion and Choices, a national nonprofit working to improve care and expand options at the end of life. Rebecca has worked in public health policy for more than 2 decades, advocating for tobacco control, access to health care, and gun violence prevention. She ran for the Minnesota House of Representatives in 1999. Rebecca serves as a board member and development director for the League of Women Voters Minneapolis. Rebecca, thank you and welcome.
Thank you all. I'm going to now share my screen, so everybody hold on. Got it. Thanks everybody for joining, coming back. First of all, I want to tell you, I sound bad, but I feel fine. This is the leftover crud from a wonderful holiday spent with my grandchildren in Virginia, and they're little vectors. But I'm feeling pretty good, but I've got the residual crud. So don't worry if I sound kind of funny, I'm feeling just fine. So thanks for joining us tonight. And for some of you, this topic, you'll remember we started working on this back in 2019. And so tonight's idea is that I kind of give an update on where things are at, a little bit of a refresher. And for some, this may be hearing information for the first time. So I'm going to try to do kind of all of those things. And we will welcome questions at the end of the presentation. So I want to start out with a really simple definition of medical aid in dying. It is a specific medical practice in which a terminally ill adult who has sound mind, complete mental capacity, may ask for and receive a prescription medication that they may then self-administer for a peaceful death, if and when they choose. A lot of people will say, oh, you mean death with dignity. Yes, this is the process that is in the Oregon Death with Dignity law. And I'll talk a little bit about semantics, but it's a very, very specific practice. And I'm going to go through a little bit about what are the criteria and how does it actually work. I think there are a lot of sort of ideas about it, maybe some misinformation. And so if you have any questions that aren't cleared up, that's what we'd like to do at the end. So the reason this came up back in 2019 is that Minnesota has actually had legislation called the Minnesota End-of-Life Option Act that has been introduced actually as early as 2015 by Senators Chris Eaton and Representative Mike Freiberg. And this legislation is modeled on the Oregon Death with Dignity law. So back in January of 2019, our Minneapolis League Program Committee decided to start with a very, very comprehensive report from the League of Women Voters of Utah. Back in 2016, they created a Death with Dignity report that they used as the basis of developing a position. And so we started with that report. We added some more updated information because their report covered through 2015. We created an addendum with some updated information up until 2019. And then we had a civic buzz. We had a We the People recorded back in 2019. And then we also did a series of unit meetings where we discussed the issue based on the report and the data. And then came together as a group and voted on whether or not we agreed with the League of Women Voters of Utah, the position that they had adopted. So, and just to mention that the other two leagues at that time that had already concurred with Utah were the Maryland and the New York State leagues. And I believe since then, a couple more having, I'm not sure who they are, but so more and more state leagues have concurred and adopted the position, which I'm going to go into. I also wanted just to take a minute and talk about terminology, because people think death with dignity, and that is the name of the law in Oregon and the law in Washington and several other laws. And I think people think that it is synonymous with the process of medical aid in dying. The use of the term death with dignity is becoming less and less as we go forward, in part because of some pushback from people who felt that saying this was death with dignity suggested that other people who may not choose this are not dying with dignity. And that is certainly not the intention. Dignity is determined by the individual. And so Senator Eaton had decided on the term end-of-life options, which is what the California, Colorado, and some other states had adopted as more sort of simple, explanatory, not offensive, and not suggesting that, you know, there's only one way to die with dignity. So the Minnesota bill is called the End-of-Life Options Act. The process is known as medical aid in dying, but you'll hear the terms used synonymously. You'll also hear the term assisted suicide, physician-assisted suicide, and I'll talk a little bit more about why that terminology is really not accurate, and why that we try to make a real distinction between what is assisting a suicide, which is illegal everywhere, and what is medical aid in dying, which is now legal in 10 states. So yeah, here's a map that shows, ignore those green square or the yellow squares if they're confusing. The aqua or teal colored states have authorized the practice of medical aid in dying. So there are 10 states plus Washington, DC. The dark blue states have introduced legislation to pass the law. So, and then the gray states, there has been no bill introduction there. So you can see that, and I'll put a little list to kind of go through. Whoops, if I can move this forward. There. Going back to the very first law passed in 1997, it actually passed in 95 originally, but took effect in 97, and that was in Oregon and done by a ballot initiative. So they've had the law there for 23 years or more. Washington State was second, again by a ballot initiative in 2009, and that had followed a series of legal challenges, including getting all the way to the Supreme Court, which some of you may recall was Sandra Day O'Connor who wrote the opinion on this, saying that there was nothing really in the Constitution that said one way or the other, and this would be something determined by the states. So this is a state by state issue, which is why we don't, as a state, necessarily look to the League of Women Voters US to take a position on this, because it's not a federal issue. State leagues, some are, and some are not taking positions. So that's why it's a state level issue. Montana actually had a court ruling in 2009, finding that there was nothing in the Constitution that prevented this, so that it is legal. Vermont was the first state to pass it by legislation in 2013. And then in 2015, from then on, it's been a rapid momentum of more and more states adopting legislation. California and then Colorado by a ballot initiative. And I like to point out that if you remember the 2016 election, there were two candidates for president in Colorado. One got 42% of the vote, one got 43. It was very close. But this ballot initiative received 68% of the vote in that state. It was the highest receiving ballot initiative in history in Colorado. Washington, D.C. passed the law in 2017. Its city council did. Hawaii in 2018, and then 2 states in 2019, Maine and New Jersey, and last year, New Mexico. So about 22% of Americans now live in a state where medical aid in dying is legal. So I wanted to go through kind of where medical aid in dying fits into your thinking about end-of-life options. So if you think about when someone has a chronic disease and they're coming toward the end of life, what are the options that they have? And of course, pursuing all life-sustaining treatment is an option and probably the default option. People can also refuse life-sustaining treatment. They can try it and then discontinue it. They can choose hospice care only, which is comfort care, and where they stop treating the disease, but just elect comfort measures. VSED is an acronym that stands for voluntary stopping eating and drinking, which is what some hospice patients or chronically ill people will do toward the end after they've tried all the treatments, or they feel the treatment effects are worse than the disease, and they may just lose their desire to eat and then so stop eating and drinking, and usually die within 10 to 14 days. And then some patients receive sedation to unconsciousness, where they're given medication that will put them into a coma. And then again, they may dehydrate over the course of 10 to 14 days. If they need so much medication because of pain or discomfort, that may also suppress the breathing. So that is something that also is an option. It's not something a patient will request because generally these patients are not able to speak for themselves. And then medical aid in dying is why I would put sort of as an alternative for people who might choose voluntary stopping eating and drinking. This would be an option for them. So I'm going to walk through. This information is really about the Minnesota legislation specifically, but I'm covering the main provisions, which are basically the same in all of the states that have authorized this. Where there are differences, I'll point those out. But so basically, in order to qualify for this, to have this as an option, you must be at least 18 years of age. You must reside in the state. You must have a prognosis, be terminally ill with a prognosis of 6 months or less, which is the prognosis needed to enroll in hospice. And you need to be mentally sound, which means able to make your own healthcare decisions and understand the consequences of those decisions. And then finally, you need to be able to self-administer the medication. And usually that means swallowing, although there are some instances where there are alternative methods of self-administration that are not swallowing. And the process is also prescribed in the bill. A patient first starts this by submitting an oral and written request to their physician. There's a certain form they fill out. The attending physician, and I will note, NP is nurse practitioner, and this is where we might differ from other states. Actually, in every state except New Mexico, only physicians can participate as either the attending or consulting provider. However, New Mexico was the first to include nurse practitioners, and there have been efforts to include nurse practitioners in California and other states. And so our bill included nurse practitioners as long as they have independent prescribing authority and already function as independent practitioners equal to physicians, then they can also serve in this capacity. So that person must determine the eligibility, review the prognosis, review the mental status, provide a full list of alternatives to educate the patient, be sure they know all their options. Even they must be sure to offer a referral to hospice if a patient is not already enrolled at the time the request is made. And then they must refer that patient to a second physician or NP to confirm it, go through the steps again. If there's any question between the two physicians or nurse practitioners about the mental status, then they would be referred to a mental health professional who would make the final determination. There are safeguards in the bill, which is similar to the safeguards in other states. There's absolutely no requirement for any healthcare professional individual to participate or institution. And then there is liability protection for health professionals who follow the steps according to law. They're protected from criminal and civil liability. And then I put this little quote at the bottom because this kind of clarifies a little bit about the idea of suicide, which is the bills very specifically say these actions do not constitute suicide, assisted suicide, mercy killing, etc. And that's really important for things like life insurance. That's a question we often get. Will this affect my life insurance? No, because this is not legally the same thing as suicide or assisted suicide. So that's the basics of the bill. And I wanted to then kind of go through for you some of the supplemental material that we included with the Utah report. And I encourage you all to take a look at the Utah report. I think they did a nice job of covering all of the main issues. So we updated some of the year-end data reports and positions of the medical associations and survey information. So I'll just say that almost every state where this is legal, there's a reporting requirement, so that every patient who makes a request for medical aid in dying, there's a form submitted. If they actually get the prescription dispensed, there's a form submitted. So we're able to track the usage, and they ask some common questions among the patients who use this. It's all anonymous and unidentifiable, but cumulative. So for example, this information, and I'm using this information that's in our addendum. There has been more updated information since then. There have been reports in 2021, 22, but this is what was available to us at the time. So this comes from the Oregon 2020 report, which shows that since 1997, so for that entire 23 years, a total of just under 3,000 patients received a prescription for the medication, and just under 2,000 ingested the medication. So that's about 2 out of 3. And that is important because that's really common. If you look at the data across the states, it's generally 2 out of 3 who actually receive the medication end up using it. About 1 out of 3 do not end up using it. Also, the top diagnoses among patients who use this is pretty common across the states as well. The number 1 diagnosis is cancer. The vast majority have some form of end-stage cancer. The next largest group typically is neurodegenerative disorders, such as ALS. For the first time in 2020, cardiovascular disease and lung disease surpassed the neurodegenerative, but typically it's cancer, ALS, and then heart and lung disease. And that's important to note about that is that those tend to be diseases where the prognosis is the trajectory of the illnesses can be somewhat determined. So people typically go on a decline, and then as they progressively lose capacities, that death is more and more imminent. Unlike, for example, heart disease, some heart diseases where they have a terrible incident and then they bounce way back, and then they have another incident, then they bounce way back. And you're less able to determine, what is really going to be the final for this person. These diseases are more slow progression. About 95% of the patients who requested this in 2019 in Oregon were enrolled in hospice care, and 92% of them died at home. So, and the important thing about this statistic is that this is not an alternative to hospice care. So I think some people think, oh gosh, this would be, they'd go right to getting a medication. But actually, people want to live as long as they can, and they go as long as they can. And most folks are in hospice care. But when they get to a certain point, they may decide they've had enough. But they are not rejecting comfort care, they're wanting to use it for as long as possible, typically. And then the vast majority are white with higher educations. And I mention this because some of the same concerns come up now that came up 20 years ago, which is, this is something that can be exploited, used against poor, minority, disabled people. And fast forward 20 years, it's really more of a white privilege. That's kind of how it has become, because most of the use is by more highly educated, slightly higher income, mostly white people. Some more data. In the year 2019, there were 142 physicians in the state who wrote prescriptions, the 370 prescriptions that year. And I think that just shows that, it's a small number of physicians who are really at the bedside doing end-of-life care, mostly primary care. And there's not just one or two doctor death out there. This has been integrated into end-of-life care. And there's been no history of any abuse. There's been no physician discipline. There's been no legal action in Oregon in all those 20 years. And the Disability Rights Oregon organization has testified that they've not received a single complaint. They have received complaints that some people with swallowing disorders feel discriminated against because you have to be able to self-ingest and they can't swallow. So again, it's kind of turned on its head from what some of the concerns were. And if you want to dig into it, the Oregon report has a lot more detailed information about what medications are used, how long it took before the patient stopped breathing, et cetera. So there's the Oregon data is actually the most comprehensive. Most other states have whittled back the requirements to make it less cumbersome. Also, the Utah report talked a little bit about where various medical organizations stood at the time, and there have been changes since then. And we pulled out some of the most notable ones. I think the biggest one is that the American Academy of Family Physicians in 2018, I believe, withdrew its, historically medical societies have just been opposed to this. It's wrong. They withdrew that. And I think that the standard view now is that physicians disagree, kind of like the public at large. And medical societies are no longer saying this is right or wrong. They're saying, there's differences of opinion, there are ethical challenges, and doctor-patient make their own decisions. And so the Academy of Family Physicians, the Academy of Hospice and Palliative Medicine, the American Academy of Neurology, the Nurses Association, all of those actually took an affirmative sort of, we're now neutral on this. We're no longer against it. We're not for it, we're not against it. And then the American Medical Association also made an addendum to its code of medical ethics, stating that this is not, the physicians who practice this are not violating any of the ethics of the code of medical ethics. And then 12 state medical societies, including the Minnesota Medical Association, have also adopted neutral positions. And then we had some survey results from Minnesota that we included that were specific. This was a statewide survey that showed overall 73% of Minnesotans. And the survey question it really laid out the definition in the question. So there was no confusion from people about what does that mean? What does medical aid in dying mean? What does assisted suicide mean? It says, if a patient is terminally ill, da, 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 da. So the question was laid out. And then also broken down by political affiliation, which you see Democrat, Independent, Republican majorities across those. Also regionally, Greater Minnesota and the Metro. And then even by religious affiliation. And so all of the people who with religious affiliation or even without, a majority supported. I pull out Catholics to note because even though the Catholic Church is one of the strongest opponents, Catholics as a group are supportive. And then people with living with a
Support.
disabled person in their household, that 77% also supported. And I point those out because those are some of the arguments that you hear against this. Oh, I hear somebody in the background talking. And then the other survey information that we had was a state fair poll, which we know is gospel, right? The Minnesota State Fair Survey, and it was done in 2016. And this is the actual question as it appeared on the survey. And you can see 68% agreed. Yes, they thought that that should be allowed. So the Utah report also, I think, did a nice job of going over the pros and cons, which I'm just going to mention, and we can talk about more if you have questions about it. You know, the argument for it is that this is about individual autonomy. The focus really is on relieving suffering, and it's safe practice. There's no evidence of abuse. The cons tend to be it's morally wrong, or it goes against a doctor's oath, inappropriate for physicians. Some will say it's unnecessary. Hospice can relieve suffering without hastening death. We don't need this as an option. And then, of course, the concern that this is a slippery slope. It will cause, you know, abuse, lead to euthanasia, especially for people in minority communities, the elderly or disabled. And then we also, as part of the study and part of the Minneapolis League looking at it, we just said, well, you know, why would the league even take a position on this? And does this align with our so-called values? And we found that there were several ways where this was an issue that the League of Women Voters would care about: autonomy over one's individual personhood, individual privacy, religious freedom, access to healthcare, and then noted that this is a state level issue. So the Minneapolis League, although we took this up, our goal was really to bring it to the state level so that it could be discussed at the state level and decided across the state. And so here's the actual Utah League of Women Voters Utah position with which we conferred. The League of Women Voters believes that, that state laws should grant the option for a terminally ill person to request medical assistance from a relevant licensed physician to end one's life. The League of Women Voters believes such legislation should include safeguards against abuse for the dying and/or medical personnel. So rather than try to wordsmith things, we thought that captures the essence of it. And I believe we had 30% of our members voted. People voted at unit meetings, and at-large people voted online. And of the voting group, 95% supported concurrence. So it was pretty significantly clear. And so this is kind of where my update starts. So what happened then is that we, you know, the intention of the Minneapolis League is to take this to the Minnesota annual meeting for asking them to concur with the position also, so that the Minnesota League as a state league would have an official position. And then we would be able to lobby on the bill if we wanted to, if it, you know, if it became active or whatever. And so we took that to the, well, in 2020, we were all set to go. And of course, COVID hit. And so the annual council meeting that year was canceled. So everything was just put on hold for a year. So we came back again in 2021, and this time to the annual convention, and we proposed the information. You know, we had done what we could to try to share the information with other local league chapters, because this is a statewide issue. So we sent the report out to the state presidents, the league, local league presidents. We sent, you know, the addendum, we sent our talking information, we offered to do presentations. Actually, a couple of leagues did take us up on that and ended up joining us in concurrence, Golden Valley, and I think Wayzata Plymouth. But clearly a lot of leagues, it kind of took them by surprise. They didn't know about this, they weren't prepared. And yet we still got 58% support for concurrence. Unfortunately, we needed 60%. So we were something like 12 votes short of adopting this position last year. So we realized, you know, after this, we formed a committee We have something like, I think we have between 9 and 12 pretty active members from 5 or 6 different leagues. And our goal really is to get out the word. So we were doing a series of educational forums, and we have a couple more scheduled for later this month, 2 or 3, where we're just doing this kind of presentation where I'll do this in a little bit more in-depth information to educate the leagues. And then our plan is to reintroduce it, come back to the council meeting in April, again, asking for concurrence for the state league to adopt this position. So that if the bill, and obviously this is the second year of a 2-year session, the bill was introduced, may or may not move this year, but we know that momentum for this issue is growing, and it's going to come back. So it's going to be, it's only going to expand. More states are likely to pass it this year. Every year there will be more. And so that's what we're planning to do. And so I want to leave plenty of time for questions. I'm going to stop sharing my screen, and Ellen, I'll go back to you and let you lead the questions.
All right, Rebecca, thank you so much. That was so informative. And this was the first time for me hearing it, and really appreciate you updating us on it and all of your hard work. So I have muted people as you came in. You can unmute yourselves now and ask your own questions of Rebecca. And I'll keep an eye on the chat if people want to put them there and have somebody else read them. I can do that as well. So I hope you have a lot of questions.
I also want to say that I see that Dot Lilja is here, and she was on the original committee for the Minneapolis group. And then there are several more folks here who are part of the End of Life Options Committee. And so I welcome them to also chime in to this conversation as questions come up, or if any of you have any comments you'd like to make, Dot or Susan or Diane and Diana.
Rebecca, I'll start with a question, and that is, what happens if a person has the capacity to make this decision and gets the prescription, but then through the course of their illness really loses the ability to make that decision to self-ingest?
Yeah, that's a good question. And, we don't know why 1 out of 3 people who get the prescription don't use it, because that information is not tracked. We suspect that some people may lose capacity. So if they lose capacity, they will not be able to follow through and ingest the medication. And remember, most of the people in this situation, and it's really our goal, is to have everybody be enrolled in hospice so that they have a whole team, a hospice care team with them, seeing them regularly, if not daily, so that they have the support they need. So if people start to lose capacity, it may become, detectable. So people may decide to act earlier. But if they truly do lose capacity, then they would not have the option, because they wouldn't be able to self-ingest.
Right. Yeah, thank you.
Does every state literally say that you have to be within 6 months of dying and that you have to be able to orally ingest? That has this law?
Yes, those are 2 cornerstones of the law. And it's important to know that, because that's different from international law. I mean, you'll hear people say, "Whoa, in the Netherlands, they do this, and in Belgium, they do that, and in Canada, they do that." And all that is true, because it's very, very different. In the United States, you absolutely must have a 6-month prognosis. And that was selected because it's a Medicare standard, which made it an easy sort of standard to follow. And you must be able to self-ingest. would that ever change in the future? I don't know. Some say 6 months is random.
And
I
there's
think
all kinds of scientific studies that show that physicians are terrible at estimating how long people have to live.
I agree with you that doctors tend to overestimate how long people will live, which is kind of evidenced by the very short lengths of stay in hospice care. People are getting into hospice care very late in the game. But from 6 months, it becomes more predictable. When you're a year out, it's much harder to predict. And especially with the kinds of diseases that we're talking about, where there is a constant sort of deterioration, by the time you're 6 months away, it's pretty clear what the path is. So, why is it 6 months? Because of the Medicare standard, which has been set for so long. I do want to note, however, that Medicare, Medicaid, VA, no government insurance will cover this. So all of the costs associated with it would have to be borne by the patient and their family. Unless there are, actually, I should say, there are private insurers in some states that do cover this. Kaiser is a big one in Northern California. Also, Oregon State will use the state portion of its Medicaid to help cover the costs. But the state decided to do that, but no federal dollars can be used at this time. That's something that Compassion and Choices has been working on changing, but right now, as it stands, it cannot be.
What is the cost, Rebecca?
Well, the cost of the medication is probably around between $500 and $700. And then the cost would be, seeing 2 separate physician consultations and possibly a third if you needed one, and the transportation and stuff needed. So it's not, for some people, that is a lot. For some people, it's doable. For others, it's a real hardship, especially when they're dying at the end of life. So, yeah.
Can you speak to your fundraising? To the Compassion and Choices fundraising that they've had? Isn't there some fundraising for your organization?
I don't want to talk about fundraising here.
Okay.
Thank you.
Sure. I raised funds for the League of Women Voters in Minneapolis. Woo, 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 woo.
Okay.
Jane has a question.
Rebecca?
Oh, well, so Jane will go. Okay, so I actually have 2 questions. So of the unused prescriptions, what happens to them? That seems like a dangerous thing to be floating around in the medicine cabinet with those old prescriptions. And also, what's the death experience like? Is it the same medication across the United States? Is it always the same thing? And what is that death experience?
First, I'll say that historically, back in the day, 20 years ago, the medication of choice was Seconal, and it was a very high dose where you'd get 100 capsules, open the powder, dump it into a glass, add apple juice, stir it up, and drink it. Seconal is no longer available in this country. And by the way, Seconal was $50 and went up to $3,000 before it became unavailable. And so some clever pharmacists and doctors got together and have created a compounded formula of 4-drug compound of medication that sedates and slows the heart. And so that has to be prepared at a compounded formulary. Most people do not access the medication until they're ready to use it or close to ready to use it for 2 reasons. One is it's expensive. And 2 is that in both the powder and the liquid form, it does have a shelf life. So the liquid form has a shorter shelf life. But your question still remains, what happens? It's the same thing that happens to all the other medications that people who die in hospice have in their homes when they die in hospice. So hospices have really strict protocols about how they dispose of and manage leftover medications. If people are not in hospice, we have state and local drug disposal ways to dispose leftover drugs. So I would say this is no more dangerous, I think, than, somebody's bottle of Vicodin. I mean, there are people with all kinds of painkillers after surgery and stuff. So, and a lot of those drugs, all of those drugs are found in the homes of hospice patients. So I think hospices are the number one source for disposing leftover meds. The experience is, there's going to be a range of experience. On average, the person you'll prepare over the course of a day or two by having less solids, going to liquids only, taking medication to prevent vomiting about a half an hour to an hour before ingesting the medication. Then this four drug compounded is mixed with water. It tastes bitter. You have to drink it within a minute, drink the whole thing down within a minute. And then you can drink something after if you'd like. Typically, people fall asleep anywhere from 10 minutes to 30 minutes and will stop breathing in about 1 hour to 4 hours. They can go as long as 24 hours before they stop breathing. A lot of this depends on the health status of their GI tract and their body, habitus. Are they big? Are they small? So it's not the same for every patient, but there have been a lot of data being collected about what is the best drug combination to have the quickest, gentlest. So by and large, people drink it, they fall asleep, and they stop breathing.
Sharon,
Karen,
Yes, I'm intrigued by the a third that don't actually take the medication. And it seems to me a lot of them probably have just died quote naturally of their disease.
Yeah, that's,
Go ahead.
I think that, one of the benefits of that some states have found of passing these laws is that whether or not people actually use it, they feel relief and a sense of control. So that just knowing it's an option or just knowing they have it makes them able to endure longer. And in some instances, they choose they don't need it. But
Yeah.
having it gives them is sort of palliative in and of itself. I think that's what a lot of these states where this has been going on for a while are finding.
I
And
think
so-
that makes a lot of sense.
And also, you can change your mind anytime. People can get this and just decide, I don't want to do that. But, and we really don't know. We're all speculating.
Mhm.
Lena,
Yeah, what is the response to the view that this law is discriminatory against highly disabled people? For example, if you have had a basal stem stroke and you have a locked-in syndrome, it's impossible to demonstrate consent and you aren't going to swallow. Yet you're trapped in a horrible situation.
well,
That's just one of many examples of people who are not able to be served by this legislation.
it's true. For example, people with dementia, cannot qualify for this because they've lost their mental capacity by the time they're within 6 months of death. So I think that is, everything you said is true. And this is where this country has come on this piece of legislation to meet comfort that enough people are getting what they need and enough people are being protected. It's just trying to strike a balance. And I think there are people on both sides that feel it should go further in each direction. In Canada, they do inject the medication. In fact, most of the people in Canada who choose medical aid in dying there receive an injection from a physician. They don't have to ingest it. I spoke to a Canadian doctor at a conference who said to me, he thought what the Americans do is barbaric.
I agree.
Agree.
But that's
I
a very
absolutely
different
agree.
perspective, you know, that's not the perspective of so many in our country. So this really is sort of a balance. It's trying to balance, do what we can do and balance the different views of people. And even with this, you know, there are people who will object. The good thing about the legislation, though, is that no one has to participate. It really is, you know, absolutely no one has to participate. So you can just leave it. Any health professional does not have to be involved. But yeah, those criteria are in place to really make it a very clear, specific, sort of safe
Is there
process.
any discussion of, you know, perhaps down the road, letting people buy a advanced directive, say what they want when they are able to, you know, when they are of clear mind and body? For example, when they, you know, are still have their competencies but have a diagnosis of dementia, and the, you know, the future is known, to permit them to by advanced directive say what they want and access the medication.
Someday.
Well, if you remember that an advance directive is a document that names the person who's going to speak for you when you can't speak for yourself. So by definition, if you need an advance directive, you can't qualify for this.
Right. So
So,
my question was, is there any discussion of making that available to people in the future?
You know, not that I
By
know of.
advanced directive, say I'm
Right.
directing
Yeah.
my spokesperson when I reach this point, you know, to request this medication.
No, not that I'm aware of. I think that there has been a stepped up effort to help people include in their advance directive a special addendum that if they do receive a diagnosis of dementia, that they want to decrease the level of care they receive and the level of interventions, and even reduce food and water intake. So, you know, a lot of times people who are living with dementia will get maximum treatment for things like they get pneumonia and they get treated. You don't have to be treated for pneumonia when you have dementia. You don't have to be treated for certain things, but only if you put that in your advance directive. So those kinds of things are ways to shorten the amount of time that you live with dementia. But medical aid in dying, as to give them a medication or whatever, that's never been discussed as an option that I'm aware of, officially in any way.
Kathleen,
Rebecca, do you have can you give us a kind of a read on what are the possible chances that this bill, when it is introduced, would be passed into law? And if so, how long you think it would take, how many years before we can actually get a statute in place?
Oh, Kathleen, I don't know. What I do know is that the legislature, as we all know, responds to the voice of the people. And the more people who care about this issue raise it with their legislators, talk about it with candidates, the higher up the hierarchy it will go in terms of priorities. Right now, they don't hear a lot. This issue is, you know, a lot of the people who are speaking out for this are either terminally ill themselves or, you know, have recently lost someone. So even though this affects all of us, we're all going to die. I think the intensity of the demand for the issue is going to have to increase in order for lawmakers to really hear and start reacting. So that's, you know, every group that gets involved, like the League of Women Voters, helps increase that possibility. Who knows? I don't know. I don't know how long it could take. Some places, you know, I know Hawaii took 12 years, but California did it very quickly. So
Thank you.
So
one final comment I will make is that if you're somebody on, if you're involved in your league, whether you're with the Minneapolis League or another league, and you care a lot about this and you want to see it pass, get involved in going to council. That's where the vote is going to happen. And the people who go to council representing their leagues are the ones who are going to vote on this. So either go to council, volunteer to go, or talk to the person who's going to council from your league, and ask that person to vote for this, on behalf of your league. If your league, wants to take a position, say, we support this, and, we direct our delegates to vote for this or whatever. But the more that you can actually get delegate, because we lost this the first time around by a very small margin. And 58%, like I said, supported it, but we needed 60. So, and a lot of people just were caught unawares.
So you're gonna be going through that process again at the Minnesota level?
Yeah, we'll be introducing it to the state council and asking for concurrence. And that means that all the state delegates at the annual meeting will have the option to vote. I don't know a lot. Susan is on the board. Do you want to say anything about council? Do you know anything more about it, Susan?
Yes, I do. If the board recommends it, the Minnesota board recommends it, then it becomes, you don't have to have the 2/3 vote that you had to have, or 60% vote. So and it also, the league cannot lobby, the Minnesota League cannot lobby against anything or for anything without approval. So you have to get it approved by the state league to be approved or not approved. And we would do that at council.
Do we know the dates for this council, Susan?
Yes, it's April 30th. It's a single day and it's April 30th.
May I ask a question? I was part of the group that was at whatever the last year's annual convention, and for the state league, and there were some leagues that said they hadn't looked at the material, and so they were opposed. Is work being done with some of those leagues, or is that an excuse to vote no because they opposed it?
I think a lot of leagues genuinely didn't have information. And yeah, so our committee has been reaching out, and I think we have 6 or 7 local leagues that have asked us to come give them information. So yeah, there are a number of, I can't even name them all, but like 6, 7, 8 leagues have signed up, have invited us to come and give this kind of presentation so that they can get the information ahead of time. And frankly, that's what we want. We did do a webinar ahead of the annual convention, but it was just not enough people were able to get there to do it. But a lot of this is just about getting the awareness out before the meeting so folks know what they're voting for.
Judy.
Quick question. Yes, hi. I think this might be a question for Susan Clark. Does adopting a position at the state level automatically mean that the state would advocate for that issue?
Well, if it passes at council or convention, then the state league could, if they want to, actually go ahead and lobby for the position, actively lobby. And we have several lobbyists under our purview. We have Nick Harper and Michelle Whitty that are actual registered lobbyists. So they could lobby for that and could get it passed. We hope, but we don't know. I mean, nobody representing the league has taken this to them. So we don't know if they will pass it or not, but we can press for it as a state organization
Okay, so, but it's a
if it
two-step,
passes.
so it's kind of a two-step process. It first would have to be passed,
Right.
but that
And
doesn't
then
automatically mean that it fits in the priorities for lobbying then.
it
may fit in, I don't know.
Okay, thank you.
Susan, correct me if I'm wrong, which is that even if the state, the state lobbyists have to do their priorities, they only have so much time. But having a position would allow individual members of the league who are on their citizen lobbying, they could go out and lobby it in their,
Right.
if they wanted to. So even if the lobbyists don't officially go in and represent us, a committee of people, some of the really active, involved people might want to go and, talk to their lawmakers, and they can say that as a member of the league. So they don't have to, but they could.
Right.
It seems that I'm all for passing this law, but it seems like it's only going halfway. I mean, the comment that Canada does injections, what a cruel way for us to do it, to have to drink this awful tasting liquid. I mean, why was there not more of an effort to match Canada with injectable
I think a
medication?
big difference, Barb, in the conversations that I've heard have to do with the fact that Canada has a national health system, and our health system is profit driven. And there are all sorts of economic implications behind so many things. People will say the insurance company wants to kill you to save money, and the others will say the doctors want to keep you alive to save money. So there's all that sort of noise that really confounds intentions and motives, and that, I think, is really problematic in the political discourse arena. So it's easier for a country like Canada to do that because they have a national healthcare system and there's not a financial incentive, and it's different.
Okay, thank you. It just seems cruel. I mean, if anyone's put down a pet, it's so peaceful, the injection. And anyway, but thank you for the
And
explanation.
this process is also peaceful. It's just that certain people with gastrointestinal disease, or it makes it harder for some people. It's not equally accessible to everybody, but for most people who can use it, it is a peaceful process, if that makes sense.
It does. Thank you.
Did it go
Rebecca,
to
this
injection?
is Arnie, and I just wanted to make a comment about how good a job you've done in elaborating on this.
Thanks,
I'm very
Arnie.
enthused about it, and just appreciate that, and hope we continue that. I look forward to lobbying my legislators on this. Thank you.
Arnie's on the committee. Thanks, Arnie.
Yep.
Did they go to having to take it orally because of the Oregon law? Because we based our thing on Oregon?
I think, everything has sort of been derivative of the Oregon law.
Okay.
And that was, in the 90s. And all the concerns that we still hear were sort of more valid then. It was an experiment. People didn't really know how this was going to work. And so a lot of controls or safeguards were in place because of the concerns. And, fast forward 25 years, all of those concerns really have not arisen. So, but I think there's some slow changes in the laws. For example, in the Oregon law, there's a 15-day waiting period before the first request and the second request for the medication, and then another 48-hour waiting period after you get the medication. New Mexico has a 48-hour waiting period. California reduced their waiting period. Oregon said they can waive it for very sick people. So this whole waiting period that has been built into a lot of the laws has been found to be really unnecessary. The Minnesota law did not, that bill, I think, doesn't even have a waiting period because the process of seeing two different physicians kind of is its own built-in waiting period. So to just tack something else on there randomly just seems unnecessary. It's not saving, it's not a safety measure, it's more of a barrier. So I think slowly some of the legislation has changed over time to reduce some unnecessary barriers. But the basic safeguards have remained unchanged. Who qualifies, two-step process.
Can Minnesotans go to one of the states where it's legal to get the prescription? Or does that become illegal in Minnesota?
First of all, I want to preface this by saying there's theory and then there's reality. Theoretically, sure, you can move to Oregon, establish residency, find a healthcare system, establish care, and use the law. But people who are dying and at the end of life don't want to move. They don't want to leave their families. They're too ill to move. They don't want to change healthcare providers. So the reality is it's very difficult to try to do that. But theoretically, yeah, you could do it.
And you said, could a Minnesotan go to another state, get the drugs and then come back?
Oh,
They'd have-
no.
Yeah,
If
they
you came
cannot do.
back, your family would be at risk. If you ingested medication here that you had gotten from another state, you would be putting your family in legal jeopardy. I would not recommend that.
Judy,
Has the, oh, go ahead.
Yeah, Rebecca, obviously there must be groups that oppose it. Can you give a quick rundown as to what the opposition is to this bill?
I can tell you the political opposition, but I'm going to preface it by saying we know that most Minnesotans, most Americans support this. Most Minnesotans support this in every category. So the voices that you are hearing are the minority, the loud minority. And I kind of compare this to the gun thing. Most Americans, want reasonable gun laws, but we can't get them because of a small, vocal, powerful minority. It's not the same group, but it's the same dynamic. The groups that tend to be opposed are going to be religious-based groups, right to life organizations, evangelical, Catholic Church, and then leaders within the disability organizations. Not all disabled people. There are plenty of disabled people who think this is, but you'll hear speakers coming from the disability community, but most of it is grounded in a religious objection.
I was going to ask, has the bill actually been proposed at the state legislature? And I may have missed this earlier, I'm sorry.
Yes, it was introduced last year, but it was introduced for the first time in 2015. It's been heard 3 times since then. Never voted on. The most recent, it was heard in the House Health Committee in 2019, in September of 2019, before COVID hit.
Thank you. Do you know which legislators were promoting it?
Senator Chris Eaton and Representative Mike Freiberg.
Thank you.
Oh my gosh, no one's keeping me on time.
well, this has been so interesting. Last call for any more questions?
There's a hand up.
All right. Well, thank you, Rebecca, so much. We really appreciate this.
Thanks, everybody. I hope this wasn't redundant, so good.
Thank you. Thank you. Very good.
Thank you.
Thank you.
Thanks to all of you for being here too, and hope to see you next month when our topic will be redistricting. Thanks a lot.
Alrighty.
Thank you. Thank you for today.